Pain Management and Opioids, Balancing Risks and Benefits, Part 4, Understanding Opioid Use Disorder. An overlap exists between chronic non-cancer pain, chronic opioid therapy, and opioid use disorder. This overlap is complex, as it is not easy to determine whether a patient with a chronic pain problem is being treated appropriately or if the patient on chronic opioid therapy has developed opioid use disorder. A question that is always asked is, what is the risk of developing opioid use disorder for patients on chronic opioid therapy for chronic non-cancer pain? In the United States, the incidence of opioid abuse has been reported to be as high as 26% in patients receiving long-term opioid therapy, along with a 24% incidence of misuse among patients on chronic opioid therapy. It is important to identify patients who are at risk prescription opioid misuse and abuse. Factors such as mental illness and a history of substance use disorder increase the risk of prescription opioid misuse or abuse. What is addiction? The American Society of Addiction Medicine's definition of addiction is a primary, chronic disease of brain reward, motivation, memory, and related circuitry. This is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. In simpler terms, addiction is the continued use of drugs or activities, despite knowledge of continued harm to one's self or others. Diagnostic and Statistical Manual 5 Criteria. Substance use disorder. The most recent version of the Diagnostic and Statistical Manual of Mental Disorders, the Diagnostic and Statistical Manual 5, combines substance abuse and substance dependence from the Diagnostic and Statistical Manual 4 into the category of substance abuse disorder. Additionally, compared with the previous versions, the terms abuse and dependence are no longer used when characterizing substance abuse. A patient's substance use disorder is classified as mild, 2 to 3, moderate, 4 to 5, or severe, greater than or equal to 6, depending on the number of criteria a patient meets. Diagnostic and Statistical Manual 5 criteria for substance use disorder fall into 3 categories. 1. Tolerance and withdrawal, which are not valid if the patient is taking an opioid. 2. Loss of control, using larger amounts and/or for longer periods, inability to cut down on or control use, craving compulsion, and increased time spent obtaining, using, or recovering. 3. Use despite negative consequences, role failure at work, home, school, social, interpersonal problems, reducing social, work, recreational activity, physical hazards, and physical or psychological harm. The questionnaire can be downloaded from the Diagnostic and Statistical Manual 5 to help guide inpatient assessment. By adding up the number of criteria a patient exhibits and following the scoring mechanism, clinicians can determine if their patient is suffering from opioid use disorder. It is important to note that just because a patient has a prescription for an opioid analgesic does not mean that they cannot develop opioid use disorder. Therefore, it is important to assess all patients with chronic non-cancer pain who are on chronic opioid therapy for opioid use disorder and screen at-risk patients. When talking to patients about opioid use disorder, it is important to use the appropriate terminology to reduce any stigma associated with possible addiction. Patients on chronic opioid therapy should be aware that physical dependence and tolerance are normal occurrences when taking the prescribed opioid as directed and are not a sign of addiction or opioid use disorder. Additionally, problematic or aberrant behavior, e.g., unexpected UDT, need for an early refill, does not necessarily mean a patient on chronic opioid therapy has an addiction problem or opioid use disorder. In these cases, it is important to talk to the patient and determine the cause of the aberrant behavior and what steps should be taken. The brain, relationship to analgesia, opioid use disorder, and withdrawal mu opioid receptors, MOREs, are widely distributed in the brain. The periaqueductal gray area subserves analgesia, so when an opioid analgesic is taken, MOREs in this area are activated to provide analgesia through different mechanisms. When an opioid analgesic is taken systemically, it will also reach MOREs in the nucleus accumbens, which is part of the limbic system, and is the part of the brain that subserves reward or euphoria. Therefore, when a patient takes an opioid analgesic for pain, he or she may also experience a rewarding feeling such as relief from anxiety, euphoria, or relaxation. This feeling may lead to problematic behavior, including opioid use disorder, with prescription opioid analgesics. Taking an opioid on a regular basis can lead to physical dependence and withdrawal, and this occurs in the locus coeruleus, which is the main noradrenergic center of the brain. If an opioid is withdrawn suddenly, the locus coeruleus secretes excessive amounts of norepinephrine. The opioid kept the norepinephrine in balance. MOREs in different parts of the brain serve different purposes. Substance use disorders take time to develop and start with the intake of a substance, which is found to be pleasant or euphoric. This is called the binge intoxication stage, and euphoria occurs because dopamine and endogenous opioids are released by the drug in the limbic system. As use of the drug continues, tolerance, physical dependence, and withdrawal begin to occur. Now, instead of using the drug for pleasure and euphoria, the person is using it more frequently to alleviate the negative symptoms of withdrawal. The neurotransmitters corticotropin-releasing factor and dynorphin play a role in this stage. This stage has been termed the dark side of addiction or negative reinforcement. The final stage, which causes impairment in prefrontal cortex, is associated with preoccupation with the drug use, craving, and anticipation of using the drug, and is a continuous cycle that leads to impulsive and compulsive drug taking. The neurotransmitter glutamine plays a role in this stage. These behaviors and anxieties lead to the concept that addiction changes the brain and substance use disorder is a chronic brain disease. Vulnerability to opioid misuse or opioid use disorder. Most people who are prescribed an opioid for chronic non-cancer pain will not develop opioid use disorder. There are factors that increase a person's vulnerability to misusing an opioid or developing opioid use disorder, such as psychiatric comorbidities. In these patients, the opioid analgesic is not relieving just pain, but also may be relieving anxiety, depression, and symptoms of PTSD. A study of prescription opioid use among patients with mental health disorders found that 18.7% of patients who have mental health disorders in the United States use prescription opioids, and 16% receive 51.4% of the opioids prescribed each year. This study showed that the population most likely to misuse or develop opioid use disorder is receiving the majority of opioid prescriptions. To reduce the occurrence of opioid use disorder, patients should be prescribed the least amount of opioid necessary for their specific pain condition. For acute pain, the CDC recommends initiating IR opioid therapy for greater than or equal to 3 days, no longer than 7 days. It has been found that the transition from acute to chronic opioid use can occur quickly, particularly after the first 5 days or 1 month of opioid use, or when a longer-acting opioid is used as the initial treatment. Treatment of opioid use disorder. Treatment of opioid use disorder combines medication-assisted therapy, along with psychosocial treatments, and should be individualized for each patient. Treatment plans should be developed to address stopping the abuse of the opioid, as well as any underlying or comorbid medical and/or mental health issues. Methadone, Buprenorphine, and Naloxone are all FDA-approved medications to treat opioid use disorder. Naloxone is available as one daily pill or a once-monthly injectable formulation, and it has been shown that the once-monthly formulation is more effective for treating opioid use disorder. The use of methadone for treating opioid use disorder can only be done through an outpatient treatment program, OTP, certified by Substance Abuse and Mental Health Services Administration. Healthcare providers cannot prescribe methadone. To prescribe buprenorphine, physicians must complete 8 hours of required training, along with a waiver, to receive a special identification number from the DEA to include on all buprenorphine prescriptions for opioid dependency treatment. There are also regulations on the number of patients a physician can treat with buprenorphine at the same time. It is important to remember that there is no specific length of time for treating opioid use disorder. Every patient is different in the time needed to discontinue opioid therapy, and patients should not be rushed through this process. It is unrealistic to expect patients not to have relapses while attempting to discontinue opioid therapy. UDTs can help identify patients who have relapsed. If a patient experiences a relapse, triggers for the relapse should be identified, if possible, and reassessment of the treatment for opioid discontinuation should be made to determine if it needs to be intensified. Other considerations to take into account are patient access and preference to the medication-assisted therapy, EG, OTP versus physician's office, injection versus pill, daily versus monthly therapy. Treating pain in patients with opioid use disorder. Patients with coexisting chronic pain and opioid use disorder are common, but represent a challenging clinical situation. If the clinician does not treat the pain appropriately, these patients will obtain an opioid through illegal means or possibly use heroin to manage their ongoing pain. Additionally, in patients who are being treated for opioid use disorder, uncontrolled pain can lead to a relapse. Therefore, the patient's addiction and their pain must be addressed together. When treating pain in patients with a history of substance abuse or opioid use disorder, clinicians should consider consulting a pain management specialist or addiction specialist to help guide the treatment. Medications that may trigger a relapse, such as pharmacologic sleep aids, stimulants, and anxiolytics, should be avoided. If their benefit is determined to be higher than their risk, careful use can be considered in certain circumstances to minimize the risk of relapse. For the management of pain, non-narcotic medications, such as NSAIDs, gabapentin, tizanidine, and SNRIs, may be good options. For patients in need of a sleep aid, mirtazapine, trazodone, and ramelteon are preferred over benzodiazepines or benzodiazepine-like medications, EG, azopiclone, jalaplon, zolpidem. When opiates are required for managing pain, long-acting, slow-release formulations, EG, methadone, oxymorphone ER, should be used. Sublingual buprenorphine can be used for the treatment of both pain and opioid use disorder. When buprenorphine is used for the management of pain, a waiver from the DEA is not needed. Opioids that metabolize into other opioids, codeine, oxycodone, morphine, should not be used to avoid confusion on UDTs. All medications prescribed to a patient with coexisting pain and opioid use disorder should be managed by a responsible family member or caregiver. Patients with coexisting pain and opioid use disorder should be closely monitored with UDTs and pill counts. Ensure that a PPA has been reviewed with the patient and signed by both the patient and the prescriber. Check the PDMP to confirm that the patient is adhering to his or her treatment regimen. Patients with coexisting pain and opioid use disorder should be involved in an active recovery program, such as Narcotic Anonymous. For some patients, cognitive behavioral therapy, rational recovery, motivational enhancement therapy, or outpatient rehabilitations programs may be more appropriate. It is important to ensure that patients with coexisting pain and opioid use disorder are receiving the support they need for their addiction issue.